With that, I'm going to introduce our next talk coming from Dr. Ian Miller. He is a trained pediatric neurologist. He was previously the chair of the Department of Neurology at Nicholas Children's Hospital in Miami, Florida. Dr. Miller is now the Vice President of Clinical Development at Marinus Pharma. And today, Dr. Miller will be discussing SUDEP and the risk in Dravet syndrome. Dr. Miller will be joining us live for a Q&A, so keep those questions coming in the chat. Thank you.
Hello, my name is Ian Miller, and I am going to be speaking to you today regarding SUDEP in SCN1A disease, aka Dravet syndrome. And we're going to be focusing on a tool called the Mort, and kind of using it in epilepsy. It's a tool that's been around for a while, but hasn't been used in epilepsy specifically. And I think it's time that we use it to help ourselves understand a little bit more about SUDEP. So these are my disclosures. I'm a pediatric epileptologist, and I was in practice for about 14 years at the hospital formerly known as Miami Children's Hospital. During that time, I was a primary investigator and/or a consultant for multiple pharma companies. And I left that position at the end of 2020, and I'm now working at Marinus Pharmaceuticals since March 1. Having said all that, I'm not going to be discussing treatment at all, and the opinions and the medical, positions, I guess, that are discussed within this talk are mine and mine alone. The other disclosure that's probably equally important is that I really hate this topic. It's super emotionally difficult and kind of hard to talk about. It's scientifically difficult because there's a bunch of stuff that we want to wrap our hands and heads around that's hard to measure. And it's kind of mathematically difficult. And it's hard to kind of conceptualize the numbers that we're talking about and what they really mean, which is kind of the whole point of this topic, is to make these easier. The thoughts that are in this talk are kind of personal opinions driven by practicality and, trying to decide what's worth saying and what's worth thinking about with regard to SUDEP. And I just want to kind of highlight the fact that it's a little bit of a difficult talk to give over Zoom, especially recorded Zoom, which is what this is, because I have no feedback from the audience. And I'm used to having way more feedback and kind of getting a sense of what families are thinking based on how they react to what I'm saying. So hopefully this is still useful. So let's discuss briefly what the problem is that we're trying to solve, and kind of make the observation that doctors really only do about 4 different things in clinical practice. They diagnose things, they provide prognosis and expectations, they provide treatment, and ideally they will help families prevent problems. And the main aspect of this talk is going to be mainly prognosis. It's kind of helping families understand how much they should care about the possibility of blank, and in this case, the blank obviously is SUDEP. And we already agreed that the topic of SUDEP is hard for multiple reasons. And so what we want is an intuitive way to understand the risks that we're talking about that hopefully is accessible not only to doctors who deal with this all the time, but also to families who have a wide variety of backgrounds. So as a disclaimer way up front, just in case you're in this talk because you're hoping to get something specific out of it, I want to make sure that it's clear. I'm not going to talk really about the history of SUDEP or do a deep dive into nomenclature or epidemiology or a scientific review of how or why it happens. We'll touch really briefly on some of these topics, but things like risk factors and treatment and prevention aren't in here at all. If you want to know those things, there are several good review articles that have been published recently. There was also a really good talk at the Child Neurology Society meeting in 2019 by an ARNP who kind of reviewed the current state of our thinking. And I also want to point out that if anybody who has the misfortune to be affected by SUDEP should know that the SUDEP registry exists, and that is the way that we will move our understanding of SUDEP forward by being able to measure it well. So we're going to define SUDEP briefly. I'm going to kind of step back and just discuss philosophy and how to think about things that affect patients, and then we'll try to bring that philosophy and those thoughts back to our current lives, and then we'll just do an overview and a summary. So let's define SUDEP, and I'll try to do this briefly. SUDEP is SUDEP, where it's sudden unexpected or sudden unexplained death in epilepsy. Both are used. Unexplained is kind of the preferred terminology at this point. But I think it's a little bit important to remember whether it includes a seizure or whether it excludes a seizure. So the question is, does SUDEP include when a seizure is witnessed and known to be connected to the death event? And the question is, does it include somebody who dies suddenly with epilepsy when you were with them and know that they didn't have a seizure? And then does it include status epilepticus? And does it include accidents related to a seizure, such as injury, drowning, or a driving injury? These are all, there's no right or wrong answer to these questions in terms of what it should be defined as. Really, this is simply a matter of agreeing on nomenclature so that we can be consistent in how we talk about it. And so this is what's called kind of an epidemiological definition that we use for consistency. And the definition is there. I won't read through it, but the short answer to these questions is that it doesn't matter whether or not you had a seizure or not. Sudden unexplained death in epilepsy is a death with or without a seizure in close proximity to it. And because of that, it really doesn't matter whether or not it was witnessed. It does exclude status epilepticus, which is a known complication of status. We'll look a little bit at those numbers. And it does exclude accidental death from injury, drowning, driving, or other injuries which happen. So having that definition in mind, let's kind of think about some deep thoughts, I guess, philosophically. And these are kind of psychological observations as well. You know, the whole field of psychology tries to understand or explain human behavior. Obviously, there's a really big overlap with economics. Economics is all about how humans behave in terms of their spending and what they value and don't value. So both fields, you know, want to understand the rules that determine human behavior in aggregate. And what in aggregate means is that we can talk about how groups of people behave, even though we might not be able to predict the behavior or how a single individual will act. In this discussion, we're going to be talking about relative weighting, which can also be described as relative importance or relative cost if something is bad, or relative utility or relative value if it's a good thing. And what's crazy to me about psychology that took me a long time to kind of realize is that understanding some of the rules that underpin human psychology doesn't really change how susceptible you are to those behaviors. You know, one example is that doctors say that, you know, they're going to go to a drug talk because it won't influence their behavior. But the fact is that their behavior still will be influenced by that, even though they know that it's an advertising talk or whatever. Fortunately, however, psychology can be a tool to make our lives better, which is what we're going to try to do today. So let's talk about consistency a little bit, and consistency of value and consistency of what we put importance on. Different people have different opinions about costs and utility, which is expected, but any individual person, the set of costs and utility should be consistent with each other, meaning that they shouldn't contradict one another within that same individual. So, you know, if they contradict each other, it means that those values are kind of untrue in some way, right? So if something is true, it must be consistent, but just because it's consistent doesn't mean it's true. So consistency is necessary, but it's not sufficient for a set of values or weights to be true. And ideally, human behavior and the choices that we make would be consistent, but because we're humans, we can be illogical, and they're not consistent necessarily. And being logical and consistent can help us make the choice that will maximize the result of any choice that we make by having a single framework that we always use and kind of refer back to. It'll make our choices better if we follow it. Let's talk briefly about what consistency means. It's kind of like saying, look, if Mount Everest is higher than Mount Kilimanjaro and Mount Kilimanjaro is higher than my backyard, then Mount Everest is higher than my backyard, right? And it would be inconsistent to say the first of those two statements, but then say that my backyard is higher than Mount Everest. All three of those statements can't exist at the same time and all be true. That's what inconsistency is. So it would be consistent to say, look, I really care about animals. I donated $100 to the Humane Society. I adopted a puppy. All of my puppy's visits are up to date, and I'm a vegetarian. All of those are relatively coherent. You could be inconsistent if you said, I care about animals, but I didn't take my puppy to the vet, right? That's kind of there's some natural tension in there. And it implies that all of the things that we've set out and that we try to adhere to are mutually contradictory. And the more inconsistent the claims are, or the decisions that we're making based on our framework, the more frustrating it is to try to understand. If I told you a bunch of things about how I value animals and they, you know, didn't make sense with respect to one another, it would be probably kind of confusing and annoying to talk to me because it would be hard to understand what my internal value system is. And, you know, let's just observe that when we make these statements about what's important and what's not important, there are costs or prices or value or utility hidden in all of those statements. The other thing I want to point out is that inconsistency kind of implies some contradiction or hypocrisy, I guess, in some way when dealing with choices, but that our emotions are a completely separate system in our brain that really doesn't care what our values are. We can worry about something even if we think logically about it in some other way. And we'll talk a little bit about that. We'll talk about psychology related to emotions and anxiety, for example. So up till now, everything was kind of being referred to on the basis of logic. But psychologists, and I think every human being knows that we're not always logical creatures, and our emotions can be inconsistent and are impossible to really control. You can't decide that you're not going to be afraid of something. If you're afraid of flying, even though you logically know it might be safer than driving, it doesn't matter. You're still afraid of flying because it's an emotional reaction to the thought and the idea of flying. But the good news is there are strategies to deal with that. And the strategies can be constructive or positive or adaptive. And some strategies to deal with stress and emotions are kind of negative or maladaptive. Constructive strategies would be like doing exercise, right? You do exercise and you think about how stressed you are, you're going to become more physically fit over time, and it will help you with your stress. If you smoke in reaction to being stressed about something, that's a little bit maladaptive because you still have the problem and you might feel a little bit better about it, but now you have all the health effects and the problems the smoking brings with it. Biting your fingernails, procrastinating, overeating, all of these things are examples of maladaptive coping strategies. So in general, we want to choose coping strategies that are better, and not better from a moral standpoint, but better from a quality of life standpoint, because the more of those constructive, positive, adaptive strategies we can use, the better off our lives will be. Just to kind of relate this back to what we were saying earlier, there's very often some internal inconsistency that lurks behind a maladaptive strategy. We say that we care about our health, but then we bite our fingernails and make our fingertips painful, for example. So, we're not strictly logical creatures, obviously. And even with all the positive strategies that a person can think of, it still takes effort and a little bit of like exercise. It's basically psychological work or psychological exercise to use these strategies when they are available to you. So let's try to relate this back to SUDEP. What does any of this have to do with SUDEP? Well, we want to spend our limited budget, and our budget might be energy, it might be concern, it might be time, it might be money, in a way that makes our children's lives or our lives and, generally our family's lives as great as it can possibly be. And as a doctor, like I said, I want to help to answer the question, how much of whatever should I commit to worrying or thinking about SUDEP? And should is a loaded term. Here it simply means in order to maximize your quality of life. It doesn't mean that you're a bad person if you think about it more or think about it less. And it depends a little bit on your philosophical approach to life. One philosophy that I think has some remarkable insight is kind of the Stoic philosophy, which is that if you can control something, then great, control it, and there's no problem. But if you can't control something, then you should just ignore it because it's impossible to control, and what's going to happen is going to happen, and you can't, do anything about it anyway. So why devote time and energy to it? It's a very extreme kind of perspective on things, but I think there's a lot of wisdom in that, especially when it comes to things like this that are outside of our control. So let's talk in a little bit more detail. The idea of the micro-mort that I mentioned in the title and that we'll talk in more detail about here belongs to Ronald Howard. He was kind of a management science and engineering professor at Stanford who, had kind of early ideas about this and how to communicate risk. The idea is that a mort is a unit of mortality. So one mort is one life. And the breakthrough, I think, and the realization that Ronald Howard had is that it's hard to think about one whole life. And it's also kind of hard to think about, a 1 in 10,000 chance or a 1 in a million chance. So his idea was to say, look, just like a micrometer or a micrometer is 1/millionth of a meter, let's talk about a micromort as being 1/millionth of a life. And then these 1 in a million things aren't 1 in a million, it's one micromort. And we can talk about micromorts instead of morts. So there is some difference if you kind of dive into this between a micromort, which is a risk from one event, or a micro life, which is kind of the total risk aggregated over a long period of time. So that's not super important. We don't need to dwell on it, but just realize that both of those terms might appear in our talk, and it really relates to whether or not it's an instant in time or whether it's over a person's lifetime. So we can think about what our values are today, right? So ask yourself, and I won't read through these, but all of these are different activities which have a different risk associated with them. And the question is, which one of these is scary to you? Which one of these is not scary to you? Which one of these seems like you'd want to avoid it, or which one of these do you think you'd want to make sure that you do? Implicit in all of these is the fact that you might love to ski and you might not like to bike. So that is built into your impression also. But the risk that each of these have is relatively consistent from individual to individual. So read through those, think to yourself about which seems like the best idea or the worst idea, and you can even rank them if you like. So even though they have emotional answers to you, we should all be able to agree on the logical answer about what the risk actually is, and kind of tell us what amount of worry each item in the list deserves. And the way we do that, like I said, is with the micro-mort scale. So here's the whole scale of how likely you are to die from different activities and behaviors. It defines the micro-mort there for you in the middle. And I'm going to divide this chart into two halves just so we can read it more easily, because that bottom row is kind of fine print. So if we look at the safest activities, and things that are the least risky to us, we can see that it's 1 micromort of risk to travel 230 miles by car, right? Because of the risk of an accident. It's riskier to walk, though. So walking 230 miles would have much more risk. If you want 1 micromort worth of walking risk, you're going to be done after 20 miles. You can also travel by train 6,000 miles. You can ski for a single day. If you live 2 months with a smoker, that's a single micromort, et cetera. You can also see that rock climbing, we had, I think, some climbing activities on the prior slide, that's a 3 micromort risk. Scuba diving is 5, and just getting out of bed when you're 45 years old has a 6 micromort risk. So hopefully this starts to become clear in terms of how helpful this is to talk about things in terms of micromorts, because a lot of the risks that are around us in day-to-day life are very small, so micromorts make it easier to understand. What about the left side of that original chart with the high-risk activities? You can see that climbing Mount Everest is extremely risky, 37,932 micromorts, right? Mountaineering in the Himalayas, 12,000 micromorts. Getting out of bed when you're 90 years old, 463 micromorts, et cetera. It's kind of interesting to see how getting out of bed changes. We have, 6 micromorts when you're 45. We have 100 micromorts when you're 75 and 463 micromorts when you're 90, which gels with our understanding over our lifetime that the risk of death goes up because we're getting older and older. Note, though, that getting out of bed when you're under 1 year of age is a 15 micromort risk. That's really kind of astounding, especially when we put that in the context of other things we'll look at in a few minutes. So we can also look at micro lives and individual decisions that are shown here. I won't read through this, but you can see that heart disease, cancer, and chronic lower respiratory tract infections are major risks and are the leading causes of death in human beings. You can see that less risky things like dog attacks and lightning and hornet and wasp and bee stings is much lower, and it kind of gives you a scale and a relative size of what those risks are. So we'll come back to this also with respect to epilepsy. So we can already, I think, see how micromorts are useful. It makes small chances easier to understand. It puts risk in a context that we're all familiar with. And there's a very small chance with most of these. And when you have very, very low risks, you can add them up and be able to compare them and manipulate them more easily. It's not exactly mathematically correct, but the error is proportional to the size of the risk. And when the size of the risk is very, very, very small, the error in adding them is also very, very, very small, which is convenient. One thing that micromorts relate to is what a human life is worth, right? Would it be worth spending $1 to lower risk by 1 micromort? Would it be worth spending $10, $1,000? Who knows? Your doctor might think one thing. You might think another thing about a stranger's life. You might think another thing and have a different value for a family member's life. I think that, all of us probably do. What's interesting is to look at the dollar value that the government puts on it. The United States Department of Transportation is willing to spend $6.40 in order to lower risk by 1 micromort when you look at how they budget their money and what the risk reduction actually is. So that gives you some sense of kind of how that works. And again, we can see why consistency would be useful. It doesn't make any sense to spend $6 to lower risk to a human being by 1 micromort in the transportation sector, but spend only $1 in the health sector, for example. So the more consistent you can be and marshal your resources, the better off your aggregate decisions will be. So we're going to look at some SUDEP data now and look at what the micromort risks are. We need to remember that there's some correlations that we're going to see, and correlation is not the same thing as causality, right? We might see that taking more medication is associated with a higher risk of SUDEP. That doesn't mean that taking more medications is the risk factor and the cause of the SUDEP. it might just be a marker for severe epilepsy. Similarly, younger age is associated with a higher risk of SUDEP. Cause and effect, we don't know. We don't know if A causes B, we don't know if B causes A, and we don't know if C causes both A and B, right? So it's hard to remember that when we need to, but it's incontrovertibly true. There's just no way to know. The other thing that's really frustrating about SUDEP data is that we can't measure the risk very well. And I think we have a slide on this. Yeah, the issue is that we can measure it, but really that measurement is just an estimate of the actual, universal chance of death in epilepsy. It's a bit like trying to measure public opinion, a poll. You'll get a different result each time, and the truth is kind of probably somewhere in the middle of that bell curve. But you need the number of deaths and the number of people with Dravet syndrome in order to know, and that bottom number is really, really hard to know. It's easy to identify how many people died, but it's really hard to know how big of a population they were drawn from, in part because individuals with SCN1A might not have that SCN1A mutation diagnosed yet. So they're estimates. Let's look at a few of the estimates over time, and we're going to go through this relatively quickly because I don't think the history matters nearly as much as the numbers. But the point here is that the numbers have kind of been going up as we've gotten better and better estimates over time. In 2016, the AAN, which is the American Academy of Neurology, estimated the overall aggregate risk of SUDEP as being 0.6 in 1,000 patient years. That was already kind of a little bit outdated in terms of 2014 data that was coming out, which estimated the risk as 1.6 cases per 1,000 patient years. And we also have some sense that Dravet syndrome risk is higher. And that probably is the case just based on the fact that many, many patients with SUDEP happen to have Dravet syndrome, and it's a greater proportion than the total number of epilepsy patients that have Dravet syndrome. But it's also more difficult to measure because the population is smaller. It might be underdiagnosed, and the ascertainment might be incomplete. So, again, these numbers are going up over time. These were additional estimates that were made, and risk factors that are associated with them. I'm not going to belabor these because, like we said, there's not cause and effect between them, but there are some known risk factors for SUDEP. But the best efforts to look at SUDEP in Dravet syndrome specifically were probably this paper, which is by Cooper et al. In 2016. And their estimates were that the mortality in Dravet was 15.8 per 1,000 patient years. And that of that, 9.3 per 1,000 patient years of the deaths were due to SUDEP. So there's mortality and there's SUDEP specifically. And if you convert those into micromorts, the numbers are very big. It's 9,320 micromorts for SUDEP in 1,000 overall, because since we're doing patient years, this is essentially the yearly risk, 9,320 micromorts. We can look at other causes of death and kind of understand the mortality better. We see that status epilepticus is another big contributor, but SUDEP is the biggest in this population. It also gives us some sense of when the SUDEP deaths were reported. And by and large, it's less than 20 years of age with a much higher burden in the early childhood years. So that is what was observed. Is this because fewer patients were diagnosed when they got older? Probably, but we don't know. Again, this is just an estimate. So let's kind of relate this back to our original question, which is how much do we need to worry? We said that over a lifetime of SCN1A epilepsy, at least 1,000 micromorts of risk exist. That was the original take-all-comers estimate in epilepsy. Probably there's not more than 16,000 micromorts because that's kind of a population-based estimate. And, I think as a physician, if I was counseling a patient, I would, tell them approximately 5,000 to 10,000 micromorts is probably a very reasonable risk about the lifetime chance in SCN1A related epilepsy of having SUDEP. So let's revisit the micromort scale briefly. And if we make this to scale, it's essentially the same size as, a fall, because a fall is 1 in 119. And the SUDEP risk at 10,000 micromorts is about that same size. But what's notable on here, I think, is that there are some risks for which kids with SCN1A aren't really at very high risk for, including a motorcycle accident, right? That risk doesn't exist. So yes, we have more SUDEP risk, but maybe we should be eliminated from the motorcycle accident risk. What about a gun assault? Very few of my SCN1A patients are handgun owners or gun owners. Can you still be assaulted by a gun? For sure. The public is crazy and you never know in the US, but that risk is probably appreciably lower for people that don't go to bars and aren't belligerent, et cetera. And then you have a much lower risk of opioid painkiller overdose, which is a huge, huge killer in contemporary society. So, we definitely have a big SUDEP risk. That's how big it is. And there is a silver lining to the extent that there are other risks that are very high for the general population that nobody thinks about. I mean, think about that fact. You have a child with an SCN1A mutation and you have a child who's healthy. Both of them go through early childhood and become adults. We worry about the SUDEP risk still, but nobody's worrying about the other adult being a fatality related to opioid overdose, even though that risk in reality is higher. So this is a place, again, where consistency will help us worry about it to the right degree. So let's convert the lifetime risk to a daily risk. If we think that the life expectancy in SCN1A disease is a number, well, the problem is we have no idea what that number should be. It's hard to estimate because SCN1A testing is only practical for the past 20 years or so. So many, many older patients aren't diagnosed. But life expectancy probably is not 70 years like it is for the general public. It's probably above 30 years if I had to guess. And so, just kind of pulling a number out of that range somewhere, I'd say, 45 years is probably a ballpark figure that's reasonable. And if we really take the upper end of risk of 16,000 micromorts over 45 years, what that means is that we're dealing with about 355 micromorts per year. And I promise I didn't cherry pick these numbers because that ends up being about 1 micromort per day. So that's that's how much you should worry about this. You should worry about it on the level of 1 micromort per day. It's imprecise math, but it's reasonable because these are very rare events. And it's like we saw from the histogram earlier, it's probably front-loaded in childhood and is lower in adulthood, but that's very hard to know because of the problem of testing. So, how big is the risk of SUDEP? It's about the same as walking 20 miles or driving 230 miles, right? It's much smaller than these other activities, which, might stand out. If you ran a marathon and your child has Dravet and you worry more about your child waking up each day than you worry about yourself running the marathon, you're probably not budgeting your concern in the right places because the marathon is more risky to you today than waking up was for your child. Getting out of bed under age 1, right? Nobody who's the parent of an infant thinks on a daily basis about the fact that there's 15 micromorts of risk for their child to get out of bed today, but we think about SUDEP every day, even though that risk is 1 micromort. Kind of interesting. What about playing American football? Nobody bats an eye when a healthy child plays football, but that's a 20 micromort decision, and it's a 1 micromort decision or a 1 micromort event for a patient with SCN1A to get out of bed. Giving birth, right? Kind of scary. Didn't really think too much about the risks. 170 micromorts versus 1 for each day that a child with SCN1A gets out of bed. So I hope this is a useful way to think about it and it's starting to make sense. If we choose to eat red meat, if we watch television for 2 hours, if we eat sausage every day, these are 1 micromort risk that is comparable to SUDEP, yet we don't think about these things, whereas we think about SUDEP all the time. If we're a smoker and we think about SUDEP, it's very, very inconsistent of us to worry about the SUDEP when we're not going to stop smoking. If we're obese and are not exercising to bring our millimort risk back up from 3, that's inconsistent with worrying about SUDEP all the time. So, in conclusion, Ron Howard, who again was kind of the innovator behind the micromort idea, said that to me, incorporating the principles and philosophy of decision analysis is not just learning the subject, but it's more like installing a new operating system in your brain. That's pretty profound. So the good news is you've all just had an upgrade. Your Windows update just ran, and you can all think about things in a new way that hopefully will make your decisions in your life better. The bad news is you'll have to reboot, which, to me, hopefully doesn't mean forgetting all the other talks that you're hearing this morning, but might just mean reflecting on this and, trying to internalize and contemplate some of the ideas that we've presented. The real point is to exercise our constructive coping mechanisms. The topic is inherently scary, but we shouldn't give it more weight than it deserves. We want to be consistent with what we spend our worry on because that will make our lives as rich as they can be. And the micromort is just one tool to do so. So with that, I'll thank you for your attention. If you found this talk useful, I would invite you to consider making a donation to Camp Boggy Creek, which will allow you to memorialize or honor a loved one at camp for patients with epilepsy. You can also make a donation to the Dravet Syndrome Foundation, who makes these talks possible. Thank you.
Thank you, Dr. Miller, for that talk. I'm already seeing, and I think you're seeing them too, all these comments coming in the chat thanking you for this. This is such a scary topic, as you said, and I know it's a difficult one for any of us to talk about. we don't have any immediate questions rolling in, but one of the questions we got earlier, and really just in general, I guess. So the specific question earlier was asking about SSRIs. So specifically, I think Prozac was mentioned, and there's been association with serotonin possibly being involved, the serotonin pathway in SUDEP. And so the question was wondering if medications that are affecting the serotonin system could be preventative for SUDEP. And so what are your thoughts on that?
Yeah, that's kind of the $1 million question in SUDEP. And obviously, the topic is so diverse. I didn't try to go into it in the talk at all. And I would encourage people to refer to some of the review articles that I referenced in the first couple slides, because it is a tremendous volume of literature to go through. And I think they've done an excellent job doing that in terms of those review articles. But I'm happy to address it here also. And I'm certainly not telling people not to ask those kinds of questions, because those are still appropriate, even though my slides didn't go over it, and maybe because my slides didn't go over it. But I think it's necessary that either the heart or the lungs are involved in the SUDEP mechanism. And the problem is we don't know which is more responsible than the other, or maybe they're somehow both related. I think the problem is that there are too many very compelling and very reasonable ideas about where that risk comes from and how SUDEP unfolds. So for sure, we hope that serotonergic medications might be effective at lowering that risk, but it's equally possible that they won't be and that it'll be something else. So I think so these are questions ultimately that all of us have to have individually with our healthcare providers who know our children the best and who have some sense of, how much maybe baseline sleep apnea our child has that they can help us factor in, or how much baseline cardiac irregularity there is from beat to beat variability that our child has, and they can factor in. So ultimately, there's no better person to have that conversation with than your doctor. But I think we can also say fairly definitively that we are not yet to the point where we can say the serotonergic system is the SUDEP system, and by intervening here, the risk will be lowered. And the other thing that we can say is that in the long run, what we need to really nail down which system is responsible are clinical trials that look at specific interventions. If we think about it, we don't really care why it happens. What we want is how to make it as close to zero as possible, right? And the way that you do that isn't necessarily by understanding the mechanism. It's possible that some intervention would be tried that would anecdotally be seen to improve things, and we wouldn't know why, but we would know that it did improve, right? And an example of that is a little bit like SIDS. There's a lot of similarities between SIDS and SUDEP. SIDS is kind of like sudden death in infancy with no epilepsy, right? But it's even more mysterious in a lot of ways, and we don't really know why back to sleep helps in SIDS, but we know that it does, and so we can just do that. And if we had something like that with SUDEP, we would be delighted. And the way that we get that kind of information is by doing clinical trials that look at specific interventions. And I wish that there would be a way to kind of do like an omnibus SUDEP intervention trial where maybe you randomize patients to do one particular thing, and different patients get randomized to different, interventions. And the challenge here, obviously, is that it's super uncommon. And so to show that risk is being lowered, you need a lot of patients. And it's just hard to do. It's definitely worth it, but hard translates to money in the real world. And so that's why it hasn't already been done already. Not obviously because providers don't care about it or patients don't care about it. We all do. It's just a matter of how you prioritize very important things like that versus equally important things like gene therapy that you're hearing other talks about today.
Right. I guess along those same lines, when you were counseling patients, did you ever recommend things like, having, cardiac monitoring to make sure that they weren't at any additional risk? I know, some altered cardiac function can be associated with Dravet syndrome. Do you think that's an important step that families should be seeking out?
Definitely. And again, the place to start is with the pediatric epileptologist that you trust with your child's Dravet care as the primary person. Who, obviously, there are a lot of very, very Dravet specific and SCN1A specific considerations in these decisions. And the more familiarity the provider has, the better answers you're going to get related to your child. I just because we don't have proof that a specific intervention doesn't lower the risk of SUDEP does not mean that it's not worth doing. It might be that using light bedding, using an epilepsy pillow, using a seizure alarm, none of those things are proven to lower the risk of Dravet or lower the risk of SUDEP, but there's a reason to think that they might, and they're basically free of side effects, right? There's no side effect other than the $20 that it costs to pay for a special pillow or the few $100s it costs to pay for an alarm. So if there's something that's compatible with your lifestyle that might help, for sure, it's worth trying, and especially if it's going to help put your mind at ease. So we're in an imperfect knowledge situation right now. It's getting more and more perfect, every year, and just the idea that we can test for SCN1A now is profoundly meaningful. But we're not where we want to be quite yet.
And then I had another, it's not so much of a question as a statement, but it led me to a question. So someone commented, it would be interesting to involve pediatric palliative care social workers to help define and discuss this anticipatory grief that a lot of parents experience when they first learn about SUDEP. Is that something in your practice that you ever saw, neurologists kind of helping families to connect to those programs? And do you think that would be important for families to seek out or to, talk to their doctors about?
Wow, that is a really good question. I'm partial to this topic because, my mom was a hospice nurse in her professional career, and I heard a million times about how important hospice and kind of symptom relief is. And for sure, I'm a believer in that. It's not just because I heard it a million times, it's because it's true and it makes a profound difference to patients. I think, though, that in practicality, it's kind of challenging for the palliative in a hospice system. And you're not talking about hospice, but like that's kind of a close connection in medicine, right? And so it's a lot like other things. If you go to the psychiatrists with an SCN1A mutation, that they don't, necessarily know what to do. They want to say, oh no, this is neurology, talk to your neurologist. And it gets complicated. It's an imperfect medical system that we're all functioning within too, which we all know all too well. That doesn't perfectly kind of catch the ball that is thrown to us by the disease state. So absolutely, those conversations are important. I think the most dedicated epileptologists and pediatricians go out of their way to try to help you with that, even though it's a really complicated problem. And even though, that doesn't show up on their, reports to their department and they get kind of no credit for it. I mean, it's just such an important thing that we try to do our best, even though the system doesn't really accommodate it. But for sure, if you have the ability to get external support, either in the form of a palliative physician or a counselor or a therapist or a social worker, all of those things are incredibly worthwhile. So yes, strongly encourage anyone who thinks they might benefit from it to raise that question specifically, and maybe even make an appointment. I think one trick that you can use for your child is to make an appointment with your epileptologist and say, look, I don't want to talk about the seizures today. I don't want to talk about the medicines today. I don't want you to be, going through the list of meds. Like, that's not the problem we're going to solve today. We had an appointment a month ago. We did it then. Today, we're going to talk about, grief or overall symptom and side effect minimization or alertness or whatever. So, I think as imperfect as the system is, it does allow for that kind of thing where you set the priorities and dedicate the visit to that rather than something else.
Great. Thanks. I think that's, I know as a parent, that was one thing that I had to sort of grow into, was understanding that I could direct what those visits look like and ask for what I need. And I think that's an important lesson for our newly diagnosed families to hear, especially coming from a clinician. So thank you. Mm-hmm. I think that is the last question that we had. Oh no, here's one more. Let me find it. Whew. My screens are moving. No, I think that was it. It was another person chatting in just to thank you, because this was such a unique perspective on this topic. And we really appreciate you being here to talk about it. So thank you so much, Dr. Miller.
To address everybody.